have no disclaimers. You know, I hear from all the surgeons here, with all due respect to them, actually, they talk about no use of intraoperative electrophysiology or they don't need it. Let me tell you this. If the surgeons are doing a motor cortical tumor without electrophysiology, it's criminal. If they're doing intramedullary spinal cord tumors without electrophysiology, it's criminal. If they are young surgeons and they want to learn fast and they're not using electrophysiology, probably not criminal, but they would learn much faster. If patient function of power of 3 versus power of 5 matters to you, you should use electrophysiology. If you don't care, don't use it. If the patient, you're sending patient home within a couple of days versus patient not mobile for 6 months, and after 6 months you're telling us, you know what, you did great surgery. Well, actually, my patient, I would matter. I would want him to walk in 3 days. So use neurophysiology. That's my message. But if you don't want to use it, or this is the place I work. Yesterday we talked about, and we do all sorts of surgery, but today's talk is only about spine surgery. So I'm going to tell you about these modalities: sensories, motors, spinal cord mapping, screw stimulation, and rhizotomy. So let's see. Intraoperative neurophysiology use, probably that's the use that I just mentioned, is more important than this academic use. We monitor certain functions, neural functions, by using certain modalities. And those modalities give you about the neural structure real time in sedated patient using certain modalities. And as I mentioned, those modalities. I'm going to quickly move over. We are accredited. So if people are claiming that no use, I think this should be banned. This association should be banned because they accredited us. Not only they accredited us, they accredited UCLA, Huntington's, Northwestern, and Stanford, Johns Hopkins. I don't know why they did that. Okay, American Academy of Neurology came up with these guidelines in 2012 that SSCP and MEP monitoring should be used for spine surgeries. So I'm not making this up. All right. So let's move on to, these are the reasons. Probably in the US, this is a very important reason. I hope this becomes a very important reason in Pakistan as well. But anyways, patient safety and all these reasons, surgeons are using it. These are the surgeries electrophysiology is used. In our hospital, we are using it actually in these surgeries and only scoliosis and patients with pre-existing deficits or previous surgeries, myelopathies and all of those things. But in our hospital, because of lack of staff, we are confined to these surgeries, mostly in spine cases. Majority of our surgeries are brain cases, actually, in our hospital. So I'll show you what are those modalities. Oh, before that, what was the need of these multiple modalities? The need was this. They started with SSCPs, but they realized that the patients are waking up with motor deficits with intact or good SSCPs. They figured that SSCP only is not enough, so they added motor evoked potentials. I'll quickly show you. This is how the screen looks like. This is a very complicated screen, so you're doing a lot of tests for patient safety in one screen. I'll skip that. So for all of you who do not know what happens, so this is motors. What we do here is, I showed it to you yesterday as well, but since a lot of people were not around, so you stimulate the scalp in transcranial motor evoked potentials. You stimulate the scalp using these electrodes. You send the current down. You see this red line is sending the current down. And what happens is, as the signals go down, is it the red line? Yeah, the red line. So as the signals go down, you can record from any muscle. So based on your surgery, if you are operating on cervical spine, you want to monitor all these upper limb muscles. And then, of course, based on thoracic spine, you can monitor lower limb muscles. You can monitor sphincter functions, bladder, and you name it. So based on the surgery, but this is what motor evoked potentials are. You stimulate scalp through transcranial stimulation using scalp electrodes. I use corkscrews, and you send the current down. What happens in sensories? I'm telling you this because a lot of people actually do not have this idea what happens. So in sensories, you're stimulating peripheral. You can stimulate median nerve, radial nerve, ulnar nerve, anything, and you send the signals up. As you know, sensories are ascending. You're monitoring dorsal columns. And as the signals reach here, these parts, you monitor those waves. Now imagine the surgery on cervical spine. you would imagine that this brachial plexus wave at 9 milliseconds should be okay. But this wave may be delayed at 13, and this wave at 20 may be delayed. This is how you interpret. This is how you tell the surgeon that, I'm having changes. How you do that? Your baseline is your control. You're not talking about data available online. Whatever that baseline you have in that patient before incision, that is your baseline, and you want to see, what happens during the surgery. Similarly, so I hope you understand the upper limb. So, oops. So this is lower limb. You stimulate nerves here. You can stimulate posterior tibial nerve, peroneal nerve. You can stimulate femoral nerve. You can stimulate from pop fossa if the leg is amputated, for example. Now you send the signals up. So there's a criteria, because this is a clinical meeting. That's why I'm not going to discuss, how much stimulation, what is the pulse width, what is all the technical parameters. So what happens here is that you record those signals as they go up. So for example, a scoliosis case or a tumor here, you know that this should be fine. This wave at 21 milliseconds, these are important numbers. This wave should be fine, and you would know that if surgery is happening here, this wave may be delayed or this wave may be delayed. So, this is how you interpret changes. And I would really suggest this technologist or technician is not actually trained or studied to do this interpretation. They can do this, but they're not technically studied. Should be allowed to do that interpretation. And that's why surgeons have these kind of arguments that, it didn't help and all of that, because a high school graduate is telling them when to stop. Anyways, let's move on. So I hope you understood SSCPs and MEPs. This modality I use a lot in my... Okay. I had music, but...
It's playing. Are you trying to do a musical accompaniment?
Yeah, because I was like, people will be sleeping, so let's have them awake with a little bit of music. Okay, spinal cord mapping I do in all tumor cases. What is spinal cord mapping? I actually tell the surgeon what is the integrity of the corticospinal tracts underneath, what is he's going to expect, and how I do that, I'm going to show you just by this. Dr. Doug, Dr. Orr, I really apologize, but Salman was telling me to cancel my talk, and I told him that I spent 2 days to make these animations. Where is he? He's not here? Okay. So you can enjoy a little bit of music. So spinal cord mapping, what happens is, so this is caudal and this is your head end and this is your lower body. So say, for example, if it's a healthy cord, you bring in a monopolar stimulator. It's a very simple technique. You stimulate in one pulse, about 50 microsecond or 100 microsecond each. What happens after that? That it sends the signals down, and you can record distally. For example, it's a thoracic cord, and you can record waves from any muscle lower down. Now, this is a healthy cord, under 5 milliamperes, a healthy cord. On the cord, you're not on the other, you're on the cord. This is how you get a wave. But what happens in a tumor, when you stimulate this, on 5 milliamperes, you probably would not get it. But at 10, you'll see that its conduction is very less. You would see a smaller wave. Now, even at 10, a direct spinal cord mapping is probably still acceptable. But what happens if it's even a bigger tumor and you already have patients with deficits, even 15 milliamperes of current is not enough, and you have no wave. This is bad sign for surgeons. And if this happens, so what I do during a tumor case, before the surgeon makes a myelotomy, I do this, I get the number. And whatever number it is, I want to say, for example, my number is 12 milliamperes and I'm getting waves in the lower limb. So I want to keep this 12 milliampere during myelotomy or till the end of the surgery. And I would let him continue until he sees tumor, he's taking the tumor out. If this number goes by in excess of 20%, so it goes to 15 or 16, 17, when I'm getting those distal waves, I would tell him that, you're getting to a cutoff point. So this is the difference electrophysiology, makes it. But I agree, in a lot of patients, you don't need it. If you're, if you're an excellent surgeon, you don't need it. But all surgeons go through a curve, a learning curve. So if you're a young surgeon, if you have the modalities available, do it. Anyways, so this is how mapping is. Now, so the take home is, this is how healthy cord looks like. Less current, bigger wave, distally. Bigger current, less wave, and even bigger current, bad waves, no waves. You are into dangerous territory. That's how you guide the surgeon. That is what is happening. Now, if you see this is our case. And in our hospital, the surgeons are easily giving these kind of cases to our chief resident or fellows. And they are operating. Surgeon is there, but he's not assisting him. He's totally depending on what I'm telling It's a very recent case. You can see the tumor is going all the way up to the fourth ventricle. It's going down. The same image. There's sittings here. This is post-op, but I'll show you the video. So I'll show you. So what happens here is, you see the first myelotomy here? So I stimulated here, proximal, recorded. And I got up, let me tell you this, in this patient what happened was, the distal stimulation, so distal to the tumor, and it was a big myelotomy. We actually did 2 myelotomies, and it was done by a spine fellow, not by a consultant neurosurgeon. We did 2 myelotomies. The first one, and there is another one that's going to show up. So we found out that distal most to the tumor, the response, spinal cord mapping response was at 4 milliamperes. I'll show you the waves. But proximal stimulation at 19 milliamperes. So I already knew it, and I told the surgeon, you have a lot of tumor. He already knew it. Obviously, he saw the MRIs, and he obviously had the idea. But we had a very cutoff point that, you know what, how much we can go in. This is the second myelotomy. And I was continuously stimulating. The other resident on the other side had the stimulator on. Let me tell you this. In California, I think a couple of years ago, they did the spinal cord mapping, and one patient died. They fired the neurophysiologist. They got another neurophysiologist, another spinal cord tumor case, intramedullary case came up. They did the same stimulation, spinal cord mapping. That patient also had severe ventricular fibrillation and whatever else, and they were like, what's going on? So what I'm trying to tell you is, there are technical parameters that are important. When they found out on the screen, on the machine, this patient was stimulated at 500 microsecond pulse. What I'm talking to you about is 50 to 100 microsecond pulse. That was a bigger duration of pulse. So, you know, the current spread can happen, and it can go to heart and all those areas. That's why technical parameters are important. And that's why, you know, in our hospital, even the fellows are able to do these kind of surgeries. But anyways, I'll move on. This is the wave. This was, I was talking about. Look at this wave. It's still to the tumor. If you see my current intensity, I don't know if you can see that or not. This is 4 milliamperes. Look at, this is left side, this is right side. I was asked yesterday a question, the D waves, and I'm going to go to D waves. D waves do not have laterality. You know, direct waves, anybody is familiar with direct waves? Direct waves is when you stimulate either the scalp and you record just distal on the cord. You're not going to the muscle. So you are, you're not going into the territory of multiple synapses, neuromuscular junctions, and then muscle. You're recording on the central nervous system. You are between brain and cord. Anesthesia does not matter in this patient. You can use inhalational anesthetics. So in this patient, we did this. You get this 4 milliamperes. This is distal to the tumor. So this is a healthy cord distal to the tumor. But proximal to the tumor, we got a response at 19 in the same patient that I showed you. This is how we gauged it. And we kept on removing the tumor out until it stayed at 19. And we were able to remove, I guess, most of the tumor out. Now I'll show you, sorry.
You got about 3 minutes.
All right, I'm fast. You can see here, this is unilateral stimulation. I'm seeing only one side of the cord. Left side, this is left, this is right body, not getting anything on the left. So you can easily identify the laterality as well. So this is from one of my US patients. I did it with one of the very renowned US surgeons, I'm not going to name that. But anyway, so let me show you what's going on. So he's removing this tumor. This is MEPs. MEPs are good. Now, as he's working on the tumor, this is intramedullary tumor. As you're working on this, you will see that this MEPs are dropping in the lower limbs. You see this? Now, MEPs, as I remember, as I told you in the first slide, from brain to muscle, you have a lot of synapses, multiple things are happening. It's affected by, It's affected by anesthesia, blood loss, muscle relaxation, many things. But in D waves, direct waves, we're stimulating proximal to the tumor. You can stimulate scalp or you can stimulate the cord. And you record just distal to the tumor. These D waves were intact. So we did not stop the surgery. We continued the surgery because the D waves were intact. Now, when the D waves are intact and the motors are completely gone, so the message I'm trying to say is, so what I'm trying to say is, People don't, in Pakistan especially, people don't even know about transcranial motor remote operations. Forget about D-waves. So what I'm trying to say, even motors are gone, motors are very sensitive, by the way. Even if motors are gone, we are adding up to that. We have spinal cord mapping and we have direct waves, where you're stimulating and you're recording directly, which is even more convincing. So as long as we have D waves, we will continue removing the tumor. That's the message, even if we lost motors. I'm going into more detail. Look at this. This is a patient that presented with brucellosis. Look at this normal roots exit from the cord. It's a cervical spinal cord. And I mean, these kind of patients, and if you're telling me that you can do it without monitoring, well, you're an excellent surgeon. Anyways, so we stimulated the cord, and you see we got a response in the upper limb. No response from the lower limb. Below this abscess, nothing was there. Actually, I was able to support the surgeon because he was so later on. And I was able to present that, you know what? Yes, the lower limbs had nothing. The cord was not healthy. Look at this patient. Well, this is obviously bad surgery. You can see this patient was a 15-year-old. She had a trauma in 6th year. At the age of 6, she was fused in the thoracic spine. Look at where this screw ended up in the cord. And she presented with this and only paresthesia. She was intact. And motor power of 4. I personally examined her. Her clinical examination. Motor power was 4. So we stimulated the cord. We found out where we found more intensity and producing a response. So we're stimulating here, recording distally to the muscles, and we found out that this area requiring a higher current than this. Say, for example, 10 milliamperes to produce a muscle response. Say 4 or 5 here, 2, 3 here, 5. So I told the surgeon, go from this area. You would have less intact, healthy neural tissue. And he found out there was more granulation tissue around. He was able to remove that, and he was able to fix it. That patient went home walking. Anyway, screw stimulation. So what happens?
You need to wrap up.
Okay, I guess I'll skip to that. I'll go to rhizotomy. In Pakistan, we have a lot of spastic diplegia patients, and I recommend surgeons please consider this procedure. This is selective dorsal rhizotomy. What happens here is you open the cauda equina. You know spastic diplegia. I'm not going to go into those details. You open the cauda equina. You separate the sensory and motor roots. You don't do anything to the motor roots. These are all our patients. You identify the sensory spastic roots through a method, which is an advanced EMG testing method. Then you divide those roots into more rootlets. And you identify which rootlets are more spastic. So for example, L4 root, you stimulate this sensory root only. You stimulate the sensory root and you identify L4 should produce a response at quads and TA. But if you see on EMG, it's producing a response quad, TA, EHL, gastrocs. So it's producing multiple responses. This is very spastic. Then we separate these roots into rootlets. We stimulate each rootlet. And then we see out of say 5 rootlets from L4, we cut the 2 more spastic rootlets through a grading criteria. I'm not going to go into those details. You see these waves, and we're cutting those waves. This is the criteria by Dr. Park from St. Louis. This is how we're doing it. I'm just going to show you this video, and I'll end my talk on this. So this is the patient with spastic diplegia, and this is pre-op, and this is 3 years post-op. So, and I'm sure in Pakistan, there are tons of spastic diplegia patients. This is a Tariq cord case. You can see EMG irritation. We notified the surgeon. We stimulated the roots. We were able to separate the phylum. The surgery was very successful. Now, scoliosis, we'll quickly move on. Left MEPs, right MEPs. During derotation, I saw this. Upper limb is intact. Rectus is intact. Look at the motors on the left side drop. Even right side marginally drop. And then it was able to notify immediately, and immediate actions were taken, and the patient walked out of the hospital. So comprehensive surgery requires teamwork, surgeon, neurophysiologist, anesthesiologist. Thank you very much.